In this video we are going to see about the Atticoantral type of CSOM or unsafe CSOM. In this CSOM, it is a very unsafe type or dangerous type, and there will be lead to formation of a cholesteatoma. Cholesteatoma is nothing but a normal keratinizing stratified squamous epithelium, which is a content of skin that is present inside a middle ear. Normally in the middle ear there will be a mucoid epithelium present, but here in cholesteatoma there will be squamous epithelium mass will be present. This cholesteatoma is of two types. It may be congenital or it may be acquired. In congenital, before birth there is during formation of middle cleft, some epithelium is trapped inside. It will appear as a white belly mass begin intact nipponic membrane. There will be no history of perforation, whereas in acquired cholesteatoma there are two types, secondary acquired cholesteatoma and primary acquired cholesteatoma. In secondary acquired cholesteatoma there is a infection or perforation which leads to the cholesteatoma. It may be due to the perforation. There will be migration of squamous epithelium inside the middle ear cleft. Squamous epithelium from ESC migrates into middle ear along the marginal perforation. Most commonly in unsafe type there will be marginal perforation. In squamous or it may be squamous metaplasia. Due to chronic infection, the epithelium may convert from mucus into squamous epithelium. Another type is the primary acquired cholesteatoma. It is due to the formation of retraction pocket, most commonly in an area known as Prusak space. You can see this small space known as Prusak space, where the borders of it are lateral malleal ligament. This is the lateral malleal ligament. Then medially is the neck of malleus. You can see this is the neck of malleus. This is the lateral malleal ligament, and superiorly scutum will be there. Scutum, part of mastoid. Then laterally pars flexura and scutum. Inferiorly lateral pass of malleus, medial neck of malleus, then superior lateral marginal ligament. This is the most common space for development of primary retraction pocket. In acute otitis media there will be different stages, like in stage 1 there will be negative pressure inside the middle ear, so the tympanic membrane got pulled in, so suddenly this Prusak space will be retracted. The pars flexura will be retracted. This contains epithelium, squamous epithelium and mucous layer. This epithelium shed off and get infected, so this forms a cholesteatoma. Then this abnormal bone enzymes of the squamous epithelium release enzymes from lysosomes of dead cells, which activates osteoclasts, erosion of scutum, and is characteristic feature of primary acquired cholesteatoma. This due to this erosion of the nearby structures of antrum Atticoantral, this is known as Atticoantral disease. Antrum Attic region, so this is known as Atticoantral disease. This contain more dead cell and pus. Then other theories of this retraction pocket are basal cell hyperplasia and primary squamous metaplasia. But the retraction pocket area, which Whitman's imagination, is the most accepted theory. The most common site is the Prusak space. It is located in epitympanum. It is above the level of pars tensa. And then the clinical features of this cholesteatoma are there will be a conductive hearing loss due to a mass present in the medial cleft. So there will be when we see the audiometric graph, there will be airborne gap for about 45 decibel loss will be there. There will be discharge from the perforation. There will be scanty perforation. The smell will be purulent, foul smelling, blood stained. It is from in an unsafe type there will be purulent discharge and foul smelling. In Attico and in tubotympanic we seen there will be the smell may be vary depending upon the size of perforation, but here it will be foul smelling and it will be blood stained due to the erosion of bones and arteries present in the middle ear cleft. Sometimes sensory hearing loss may be present due to the organism release toxins which cause spread infection into the inner ear. Management contains investigation which is the pure tone audiometry, where we can detect the airborne gap. Then high resolution TCT scan in temporal bone can show up the erosion of bone ossicles. Then other indications of high resolution TCT scan are given. Then come to the treatment part. The treatment here is the modified radial mastoidectomy, whereas in the treatment of the safe type we have seen about the first we need to use antibiotics, then when the stage is inactive, then we can proceed for the tympanoplasty. But here it is mastoidectomy. The types of mastoidectomy includes, first one is the simple or cortical mastoidectomy or Schwartz mastoidectomy. Here we don't touch middle ear, that is we first locate the mastoid process, drill they need to drill out the mastoid content, infected part. In some conditions there will be corner septum. In these cases we cannot go into the mastoid, we need to remove the corner septum, but normally that will not be present. Okay, we fully drill the mastoid and then we didn't do nothing, we didn't touch middle ear, external ear, just drilled into the mastoid. It is indicated for coalescent mastoiditis, that is a chronic infection only in the mastoid, not in the middle ear. Then if you need to place a cochlear implant, as I said, you can see corner septum, and it is a persistent petrosquamous suture, makes difficult to find antrum. Okay. Then second is the radial mastoidectomy. In this condition we open the mastoid and middle ear as well, and we create a common wall between the mastoid and middle ear. The common wall is also removed, so a large cavity or common cavity is created as the posterior wall of middle ear is removed. But very important, this facial nerve is to be preserved. The most common cause of the facial nerve palsy is the iatrogenic facial nerve palsy, that is during surgery it may be mistakenly removed or cut off. In this we remove the conductive apparatus except stapes, because stapes is very important for hearing. If stapes is removed, the inner ear is open and it can cause complications, so tympanic membrane, malleus, incus, everything are removed. Then indication for radial extraction is in case of malignancy. Okay, if we do radial mastoidectomy, that is meatoplasty is must, that is through the external ear. Modified radial mastoidectomy, it is same as radial mastoidectomy, but conductive apparatus here is preserved. Conductive apparatus are preserved. If conductive apparatus has been damaged, it will be repaired. First primary aim of disease is to complete eradication of disease. Thus in modified radial mastoidectomy, the common wall, the posterior wall is preserved. Okay guys, let me make it clear that in modified radial mastoidectomy the conductive apparatus is preserved, whereas in radial mastoidectomy both the conductive apparatus and the mastoid is removed. Okay, then we come to another two important mastoidectomy, like canal wall down mastoidectomy and canal wall up mastoidectomy, where we can use the EAC, external artery canal also takes a, we can operate through that. In this canal wall down is not same as the modified radial mastoidectomy. A common cavity is created, but the conductive apparatus is preserved, whereas in canal wall of mastoidectomy the common wall, that is the posterior wall of middle ear, is preserved between mastoid and middle ear. Okay guys, the advantages of this canal wall of mastoidectomy is that hearing results are better due to normal positioning of tympanic membrane. In this due to the common wall, we can easily position the tympanic membrane, so it can be useful for hearing results. We can go for swimming as the common cavity prevents infection, whereas in canal wall down the infection will spread adequately again and again. And the disadvantages, the rate of recurrence of this cholesteatoma is more. So whenever do surgery, follow up is must. So we need to again after 6 months operate, and we can want to see if there is infection or not. If there is no infection, we can leave it, but if there is infection, you need to read it again. So it is used only in developed countries, not in developing countries. Thank you.